Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. My name is Anas Hassan. I'm one of the doctors in physical medicine rehabilitation. I'm in my fifth year of the training. And our topic today will be about pain management in individuals with limb loss and amputees and how to approach it. And this topic will be dedicated to health professionals, physios, OTs, nursing, and doctors. So this will help to identify what is the type of pain and how to approach it. So my objectives today will be what is pain and how we approach pain and what we know about it and how are the steps for different types of pain management in amputees. And we will discuss about the algorithm to identify the cause and how to manage it as well. And there will be shedding more of information about phantom limb pain in specifically. So starting by first slide, it's what is pain. So amputees, in the majority of amputees, there will be 80% of them having pain, which is a different type of pain from each individual. It depends on personal factors, depends on the surgical procedure itself, and how was the operation been performed, and what is the level of amputation. All of these factors contribute to, in addition to person and patient factors. We will discuss all of that and we will identify it, so that will help us. So first thing will be about prevention. So we need to know how to prevent. And if we look at the prevention itself, uh, we want to prevent neuropathic pain. Neuropathic pain is a type of pain, it's a nerve causing pain. This requires an MDT approach, meaning that in meeting with the operator or the surgeon before the amputation to make sure that we are starting with some sort of medication like gabapentin or pregabalin. This will reduce the incidence of neuropathic pain. To discuss with the anesthetist about a nerve block if possible. Nerve block will reduce also the pain, and adding the nerve catheter, which is basically a small tube that will be directed to the nerve at, like with a needle, and injecting the local anesthetic. So if we look at the outcome, this will minimize all types of pain and the intensity of the pain itself post-operatively. So, and we try to be more generous because most of the time they will have pain and the nerve directed pain. The next thing is will be in prevention is education. So if you meet the patient after, so usually that the patient will have a traumatic amputation and you just meet them after the amputation, and you need to discuss and explain to the patient that there is a sort of pain that will be affecting the limb, and the patient's anticipation about the care and how we are going to meet their needs from pain management, prosthesis fitting, and psychological input. All of this will minimize the intensity, and that's all proven on the long term. It's really important to use compression socks and PMAID. PMAID is a type of compressions that being used. It's difficult to allocate maybe at the certain time in Gaza, which is part of the trying to initiate initiative of rehab Gaza itself. But we try to see what are the other options. The other option would be compression sock. The need for the compression sock is to sensitize, to desensitize the limb itself, the residuum. And overall, this will show a good improvement and good sensation and feedback from the limb itself. So compression socks, putting compression socks on that one will help as well. So if you don't have the PMAID, PMAID is the pneumatic device that you will inflate it, compress on the limb, and keep it compressed for a time, and that will be like episodic. It's a type of therapy by the physios, and sometimes it's really difficult to find, and it's really operator dependent. But we will come to that in a point. Now, let's go for the second stage, which is treat by eliminating the cause. So now we've done the prevention. We discussed before the operation, during the operation, and once we met the patient and we educate the patient about this. So if you look at, we want to follow like a stepwise approach. We need to listen to patients' complaint. What is the pain? How does it look like? So you ask the patient, what does it look like? Is it achy? Is it shooting? Is it numbness? each type of pain is different in approach. So any kind of nerve pain, it will be more of like a numbness, of like a shooting electrical, or like vibrating inside. That's all of nerve pain. If it's achy, or if it's more local, of like a swelling or a lump you feel there, that's more of like a soft tissue, bone, and it's type of the residuum itself. So you need to know, is it physical aspect, or is it more of a nerve pain? And always, any type of pain, you need to exclude, is that an infection? Look at the wound. If there is any dehiscence of the wound, if the wound looks red, hot, painful, discharging pus, or is there any pressure sore, which is part of the cause of pain, can be caused by. You look at any change in the coloration for surrounding structures. Is there any loss of capillary refill of the soft tissue itself? Is it less? If is it less more pale than what you expect? So all of these signs help you to direct you to the approach. So you need to identify the cause of pain itself, and then you manage it. So this is how you identify. One of the thing is neuroma. Neuroma is basically an swelling in the nerve itself, which is basically will be in tibial nerve or peroneal nerve. And how you identify it is, you find that it's like a shooting once you palpate or squeeze on the limb itself, and then you'll find, oh, that's really shooting itself. So you need to know, is that, oh, that's the neuroma, because the swelling, it will be flickering on the bone, and if you press it on the bone, that will be shooting, and that the patient will be feeling problem. So that's the nerve pain. Now we go to the next stage. This is the algorithm. I know it's really a busy slide, but don't worry, we will divide it and we'll show it to you. And this is how we are going through, and we will go step by step. So first thing, now we discussed already about, if you look at the top side itself, and you can see, uh, you can see there on the top side of the slide how we already discussed that is optimizing perioperative and preoperative pain control. And then after the operation, if you find that the pain persists, so you need to start as soon as possible referring to pain management or pain specialist. It's really not available, maybe in the circumstances what we have at the moment in Gaza, but this will help you to have the principles of pain management as a physical medicine rehabilitation. We've been part of amputees. So the pain management will be basically starting on medication. If we try like pregabalin, which is Lyrica, and gabapentin, if you have this in addition to anti-inflammatory and paracetamol, these are the basics. But usually with the nerve pain, it will be difficult to manage without these medications. Now, if the pain is persist, now part of things is prosthesis fitting. Yeah, it's really helping with the pain. Unfortunately, yeah, it's not that available everywhere, but the limb itself, fitting the limb itself, helps with the pain. So that, which we try to see if we can fit the limb, and that can help with desensitizing, helping the limb feeling that there is something there. It's part of it, because the discontinuity of the nerves with the brain made that pain happening. However, with other problems, logistics happening, sometimes it's not available. If the limb is not available, so we still have options. So if the pain persists, there will be non-pharmacological options and pharmacological option. Pharmacological option, we will say, we will come to it in the moment. Okay. Uh, the next slide will be, so when before moving forward to the pharmacological option, we'll discuss about what is phantom limb pain. Phantom limb pain, PLP, is pain or discomfort in the limb, and that is no longer persist, meaning that I have pain in my amputated leg, not in the residuum. So you feel that your limb is still there, and and it's painful. So how it's painful if it's not there? So this is multifactorial factor, and it's on the different levels of micro and macro levels, and it's related to central nervous system, and the brain and spinal cord, and the peripheral nerves. And these multifactorial causing dysregulation between the impulses and the signals between the nerves and the limb, because there are nothing there, and the nerves are shouting there is a problem, and the brain translating the problem into pain in the area that is not there, because that area is already mapped in the brain, if that's absent and there is nothing, so the brain itself is alert, and the only sort of communication of the brain is pain. So that's why we have the pain. So if the limb is absent, the brain will be angry, or will say that scared, and it will cause pain. There is nothing there. It used to be there and it's not there, and the brain is sending signals to the body that there is pain, and that's why. And we need, and that is really detrimental. That's really frustrating for the patient, and it will be cause a lot of problem. And how we manage that? If you see that we are dividing in the slide it between pharmacological and non-pharmacological, I think that will be the pharmacological. It's a part of medications. I discussed this medication basically. It will be anti-inflammatory like ibuprofen, naproxen, Nurofen, acetaminophen, paracetamol itself. In addition to gabapentin and pregabalin will be the Lyrica. If it's available in gabapentin, we need to be with the generous with the doses. If these medications are not helping or reducing the gabapentin or reducing the pain of the phantom limb pain, so we will go to a next step, which is like duloxetine antidepressants, which is really effective, and all the new evidence coming there. I know that it might be that available at the moment, but we try to manage with that. Now, the medication by itself is not enough. So we need to add the non-pharmacological. Now, this where is the MDT comes to. So the importance of physio, the importance of occupational therapists, the importance of pharmacists, the importance of nursing, all as a part to help with the pain. It's not like a one-man job. It's not like a part of the, as a me, a physiatrist or a surgeon by themselves. No, it's a team work. So physios, they will help with massage, eye movement desensitizations, when meaning like you're looking at the limb, you try to move it. Mirror therapy, which is part of it. TENS therapy, which is trans-electrical stimulations of the skin. It's a small pad that would give electrical biofeedback. Is the feeling of the limb movement while you are thinking of moving it. So trying to desensitize the brain itself and the nerves with doing exercises and massaging. So these are really important, if you can see that. And then we have the pain psychologist. The psychologist is part of the team. CBT and thinking and how we adapt and cope with the pain helps to accept, help to manage it on the long term, and try to dampen it for ourselves. So it will be better to have something like this in our team, or a person dedicated in the team to talk to the patient about the pain, so they will start to accept psychologically and optimize on the long term. Now, other thing to the next to that can be between the physio and all occupational therapists is mirror therapy. It's really important. If you have any mirror, just put it between two limbs, and they will start thinking about moving one limb and the other. That will help the brain, trying to tweak the brain and making it a little bit easier for them. Okay. Now, the other thing is virtual reality, VR and mixed reality, which is where you're having the device, that's like a Meta Quest, and these devices that will help them to be engaging with some activities, similar like if Fruit Ninja, which is helping them if they are trying using their hands or they are trying using their limb, that can help to mimic the activity itself and dampen the signals of pain. Augmented reality, which is part also of virtual reality, acupuncture, and phantom exercise. Acupuncture is basically the needles, and you targeting the pain and the signals and the sensitizing of that limb itself. So this is the acupuncture. It's a Chinese method of treating pain, which is hitting the nerve endings, which is trying to amplify it and de-amplify it, the nerves. Uh, if you can see that you have different options that you can use as well. So if we go to the more in details, as I said, with the pharmacological options, we have also the opioid. I'm trying to avoid the opioid because more independent, the morphine, the codeine, all of these medications, trying to avoid it because it's not showing the good, best outcome in the long term. And then when we said that the pharmacological, we need to start early, pre-operative, or once the patient has that pain, once the patient has the amputation done. And then you start with the medication. You can start the morphine as a short term. You can start with morphine after the operation if you have. But gabapentin and pregabalin are important to start as soon as possible. That helps in the long-term outcome of pain management and reduce the complication when they start to wear the prosthesis. One of the worst complications that can happen is complex regional pain syndrome, which is preventing them from wearing the prosthesis. So it's not, if you don't have the prosthesis at the moment, try to preserve and control the pain, because if the pain persists and they started to have more like spasm and allodynia, which is really aggravated pain to touch, all of that preventing from fitting the prosthesis, because we missed this opportunity to manage the pain once they are out of the surgery with all of these modalities. So we are thinking about the long term. Okay, so we try to improve the outcome and also patient education. Patient needs to be aware about there will be pain, and we need to manage your pain and with these steps. Now, if we back to the non-pharmacological treatment, I will explain it more in details now. One of the things is, sorry for the slide, it's how we a holistic approach, and we have something. It's basically a wool or we said صوف, شراب صوف, or wool, a socks of wool that you can put it on the limb, especially during night. That will help to desensitize the skin and the limb, the residual, which help on the long term to be able to wear the prosthesis. Okay, it's skin friendly and it's comfortable to wear, and I will show some examples of these socks and a liner. This is another example of that. It's called Relax 3C liner, which is basically you can use it and that can help to, it's inside it's silicone and outside will be wool, and that will be having some sort of electrical, it's what we call electrical charges on the skin that can be limited, so that will be the nerves are not that excited. So this really helping, and we give it to the patient and we find that, oh, that's a change in the sensitization of the feeling and the sensation of the limb itself, which also less triggering for the nerves and the phantom limb pain. So this is one of the things that you can put it on. If you don't have the prosthesis, that's fine. You still wear that, and that will help you with the managing of the pain. Mirror therapy, we discussed about it, and graded motor imagery, basically that when you try to move the limb at the same time when you think, TENS, which is transcutaneous, it's through the skin, small pad that you put it on the skin, and it's a small device, you can get it. And the virtual reality is the MetaQuest or VR, PlayStation VR. All of these devices not available and in Gaza maybe at the moment, but once we start to get into the end of the war, we will hopefully that will be get this into helping patients. Refer pain management. We said that in extreme cases, we see patients, they will require nerve blocks, which is part of my work as well, doing nerve blocks for patients with chronic pain, and that's part of the things that can help as well. If all options are exhausted, now we need to go back to interventions. Interventions are really needs more expert subspecialty, and you can see that it's basically like nerve block, spinal cord stimulations, and those are root ganglion stimulation, which is not in the extreme part of it. And that's all. And thank you for that. And hope this helps how to manage pain in patients with amputees and limb loss individuals. And the sooner we start, the better the outcome in the long term. And thank you.